All right, welcome everyone to a Rafael Medina subspecialty episode. I'm really excited for today's session. Today, the focus is hepatology, and we have really a fantastic educator here who we'll learn from. So I will introduce him shortly. My name is Maddie. I'll be facilitating the session, and we have Dr. Elliot Tapper, who will be the case discussant, and he's an associate professor in the Division of Gastroenterology and Hepatology at the University of Michigan. He's been on these sessions a few times before, so some of you, I'm sure, know him as the amazing educator he is. And as our case presenter, we have Hirsch Elhens, who's an internal medicine resident at the University of Colorado. He also happens to be my husband and my co-resident. So before we kind of jump into the session, Elliot, would love to just hear, a little bit about like what you love most in your role as a hepatologist, kind of what keeps you going every day, and then also what you like to do outside of medicine these days.
The thing I love most about hepatology is the complexity of patients that there's always something surprising, and that you accumulate over practice a lot of what is largely secret knowledge. And so even though the patients are teaching you day over day, they think that you know that you knew this stuff on your own. And so they think that there's some kind of superpower for understanding what's going on in their body, why they're feeling the way they're feeling. But really, it's just that I've been listening to patients for so long now that they've taught me so much about liver disease. I don't really do anything outside of hepatology. I'm a child chauffeur. So I will leave clinic and then go pick kids up and take them to taekwondo or field hockey, and I am proud to do that.
Uh,
Yeah.
that is beautiful. That sounds like a beautiful life. I feel like we can also kind of relate to that as finishing an intern year. There's not too much going on outside of the hospital. Um, well, I know Hirsch has a really great case in store for us, and I'm just so excited to learn from your teaching. So, Glenn, thank you for scribing. You can go ahead and share your screen. And then whenever you're ready, you can start with the first aliquot.
Yeah, so I'll be presenting this case in 4 aliquots. This is a case I saw on my hepatology rotation a few months ago. It was the greatest month of my life. And this was a hepatology consult, not a primary patient. And the first 2 aliquots are really sort of intended to be, well, actually, if I kind of back up a little bit. So here at the University of Colorado, we we're like a major transplant center for the Rockies generally. So we get calls from patients from surrounding states, so from like Montana, New Mexico, asking if they can transfer their patient to our center for transplant evaluation and or a higher level of care. So the first 2 aliquots are really sort of intended to be viewed from the perspective of my attending hepatologist, and with the understanding that she had limited data, and was getting a call from an outside hospital, and the question was, would we accept this patient at our hospital? So the key thing is the first 2 aliquots, we have not seen the patient. This is purely from like phone calls and chart review, with the question of like, should we be bringing this patient in to Colorado? So for the first aliquot, my attending gets a call about a early 20s male, with a request to transfer the patient for liver transplant evaluation. He's a early 20s with past medical history of polysubstance use and presents with 2 weeks of jaundice. So a brief HPI here. So 6 months prior to presentation to this outside hospital, he moved out of his parents' house and began living with another family member. He worked and started working as a mover. And then 1 month prior to presentation, he began having dark, tarry stools. And then 2 weeks prior to presentation, he had his last drink. It was unclear how much he'd been drinking before that. And he had become jaundiced, weak, had stopped eating and drinking. But during this time, he continued to use marijuana, mushrooms, cigarettes, and kratom. For those of you who don't know, kratom, actually, I don't even know how to explain kratom, but it's like people use it sort of as a pain reliever. Um, and then on the day of admission to this outside hospital, um, this family member dropped off the patient at his mother's house, and his mother, having not seen the patient in months, was sort of shocked at how sick he looked and immediately brought him to the outside hospital ED. Otherwise, the past medical history, surgical history, family history, largely non-contributory here. And again, this is all just gleaned from chart review. And vitals at presentation at this outside hospital. Temperature was 36 degrees Celsius. Heart rate was 89. Blood pressure was 118 over 52. Respiratory rate was 12, and he was satting 100% on ambient air. On exam, he was ill appearing with dry mucous membranes, had scleral icterus, and bilateral conjunctival hemorrhages in the lateral portions of his eyes. He did not have Kaiser-Fleischer rings, according to this ED note, although I don't know how well you can see them with the naked eye. He had no abdominal tenderness. He was jaundiced. And then different notes from that time from different providers sort of gave varying histories or varying sort of examinations on mental status. One note says that he was not following simple commands, ANO to self only, whereas other notes said that he was ANO times 4. So hard to really get a sense of what his mental status was at the time of presentation. And I'll provide a few selected labs before rounding out this aliquot. At presentation, his ALK phos was 219, ALT was 152, AST was 599, total bilirubin was 5.9, direct bilirubin was 6.6, albumin was 2.6, and his INR was 3.91. And with that, I will end that first aliquot.
Awesome. And I think you said the T-Billy was 5.9. I think it was 7.9, right?
Oh, sorry,
7.9,
7.9.
yeah.
Yeah.
But yeah, Dr. Tapper, I know this is a lot of information here, but one question just to kind of help guide the discussion is that I imagine you've maybe been in the situation where you've been the attending on the other line of the phone. And I'm curious kind of what key features you are listening for, looking in the chart when trying to triage should a person be transferred to your institution for further evaluation for liver transplant. What are you looking for?
Yeah, so I really like these phone calls. Getting a call from somebody who wants your help is gratifying. So I do look forward to this when I'm on call. Unfortunately, what will happen around this context is that the interest is in transferring the patient because you're worried about them. But one of the gatekeeping elements around transfer for transplant evaluation is whether or not the patient has been actively drinking. And we do routinely do transplantation for acute alcohol-associated hepatitis, but it's usually in people where we know a lot of the story about the social history. And so very frequently you will hear, well, we're very tight on beds, and so we're going to reserve for a specific phenotype of patient with alcohol-associated hepatitis. So in general, if someone says, I want to transfer a patient, I'm going to say yes. And then I will then think, well, what's the priority here? And when I hear, oh, the patient has a bilirubin of 7.9, I know the game is afoot. There's a problem. And I just want to make sure that they're not going to have something happen to them that could result in a fatality. So you tell me about the vital signs, and these vital signs, afebrile, a blood pressure where the top number has 3 digits, I'm sold that this person is rock solid already. And then I'm worried about infection, so my feel they're clearly not in shock, but I'm going to recommend that we screen for infection because I know that person could just be hanging out for a while. People with alcohol-associated hepatitis, if they are to die, will die from a very limited number of things, and that includes infection, that includes renal failure. I'll ask about creatinine, and it includes GI bleeding. This person might be GI bleeding, and I'll want to know a little bit about the ability to do an endoscopy in the next 24 to 48 hours. And have I just anchored exclusively on the story about alcohol? And the answer is yes, for the time being, right? I'll keep an open mind about the various things that can cause severe liver injury, and I haven't heard anything else beyond the bilirubin. But given this story, right, 9 times out of 10, that's where we're headed.
Yeah. Thank you. And one other kind of guiding question for this is, are you able to frame, do you have enough information to frame this person in your mind as acute liver injury or acute liver failure yet, or do you not have enough data?
Okay, so the concept of acute liver injury versus acute liver failure is a critical one to understand, and it's super confusing when it comes to acute alcohol-associated hepatitis. So point number one about acute liver failure is that it does happen within this short term that has been described, right? So the duration of illness, a few weeks. It's typically you're going to have a massive elevation in liver enzymes, whereas alcohol-associated hepatitis, the AST is going to top out somewhere around 300 or so, give or take. That's never going to be acute liver failure. Acute liver failure can also have a bilirubin of 7.9, but alcohol-associated hepatitis is going to have 7.9 and some other some mild liver enzymes or relatively mild. And then you start talking about having an INR greater than 1.5. Both of those are shared by alcohol-associated hepatitis and acute liver failure. And then the thing that distinguishes someone with a severe acute liver injury with elevation of their liver enzymes from those who have acute liver failure is encephalopathy. But there are a couple of conflicting issues here. One is that they have polysubstance abuse, and I've heard about a number of things that can cause altered mental status. And I worry about alcohol-associated hepatitis and hepatic encephalopathy. And so once the story about alcohol is introduced, if I'm not told in that one-liner about an ALT of 5,000, I'm immediately thinking along the lines of something like an acute on chronic liver injury, like alcohol-associated hepatitis. So I did make a mistake in talking about the differential without understanding what the ALT and AST were, but the story that I was being told, and if this is you on the other end of the phone from me, you should lead with that. That
Yeah.
that would be critical to cueing me into the diagnostic and management pathway for acute liver failure.
And do I need to, should I recap the AST and
Yeah,
ALT?
maybe,
Oh,
you want
okay.
to just repeat
Yeah.
maybe just the AST and ALT and see if Dr. Tab has any other additional thoughts on
Yeah,
that
yeah.
before
Yeah.
the rest.
So the alk phos was 219, the
Okay.
ALT was 152, and
Yeah.
the AST was 599.
Okay, so I'm immediately like I'm back in my alcohol-associated hepatitis, maybe drug-induced liver injury. Things could get worse, right? But I'm still in the frame of thinking that this is an acute on chronic liver injury.
Awesome. And then maybe one last question I can ask before we move on to the next aliquot. Maybe for folks who are tuning in who may be earlier in their stages of training, who like how would you kind of explain like the definition of alcohol-associated hepatitis? How would you define that to them?
So it's happening to people who have chronic alcohol consumption. That's number one. And then two, it has elevated liver enzymes, usually not with an AST of 600, but it can happen. Normally, the ALT and the AST, when you add them up, it's going to be 5 to 600 max. And then you have an elevation in the bilirubin and maybe the INR. This is clinically what would go into the definition of alcohol-associated hepatitis if you want to enroll them in a clinical trial for alcohol-associated hepatitis. If you would biopsy them, you would see fat in their liver, you would see profound neutrophilic inflammation, and it's fundamentally different from other kinds of acute liver injuries. And so this person is not definitive of alcohol-associated hepatitis, but it certainly feels that way.
Got it.
Yeah, and I guess a quick follow-up question is if we sort of take at face value that his last drink was 2 weeks ago, does that fit or not fit sort of with the phenotype of ALCAT?
It's a classic story wherein the illness appears in a acute or subacute fashion, and it is in the state of illness that people stop drinking for the first time. So you can make a mistake thinking that stopping drinking was somehow associated with the injury. It is not. It is the stopping drinking is because of the illness that they felt related to the liver injury.
Great.
Great.
All right, should you go into the next
Yeah,
aliquot?
so I'll provide a few more labs. And so there'll be quite a bit of data here. And I will try to kind of streamline it as much as possible, but I have the EMR up so I can, if you want specific pieces of data, I'm always happy to pull them as well. And again, this is all sort of within the first day or two of presentation at the outside hospital. So the BMP was notable for a sodium of 126, serum creatinine of 1.43, and an anion gap of 27, a lactate of 17. The CBC was notable for a white blood cell count of 2.8, hemoglobin of 2.4, an MCV of 110, and a platelet count of 5. And I can just pause for a second before going on just to make sure is everything
Thank you. Yep.
populated. Okay, great. And then there were some like hemolysis and heme labs that showed an LDH of 9,000, a haptoglobin of less than 20, which is low, an immature reticulocyte fraction of 26, which is elevated, 2+ schistocytes on a peripheral smear, a fibrinogen of 76, which is low, a D-dimer of 3,500, which is elevated, and they got a factor VIII activity, which was elevated at 400. Blood cultures were positive for Staph aureus. And then just kind of going through other causes of liver injury, the UTOX was positive for cannabis, but otherwise serum studies were negative for Tylenol and salicylates. But all the viral studies were negative, and I'm happy to kind of break those out if needed. The ceruloplasmin was elevated to 82, with an upper limit with the upper limit of normal being 60. Ferritin was elevated to 1,160 with an upper limit of normal being 400. And the anti-smooth muscle, anti-nuclear, and anti-mitochondrial antibodies were all negative. And then I'll quickly provide some imaging results. A right upper quadrant ultrasound showed hepatomegaly with normal liver echogenicity. There was no biliary dilation, no ascites. And there was patent hepatic vasculature and increased echogenicity of the right kidney. A CT abdomen pelvis without contrast showed mild splenomegaly, some hepatomegaly, and small volume ascites, and there was no lymphadenopathy. And then a transthoracic echocardiogram was normal, as well as a CT head without contrast. And we do actually have the CT without contrast that we can share at any point.
It's this one, right?
Yeah, that's that one.
I'll just share my screen and show that quickly.
And then otherwise, so then at this outside hospital, the patient got blood products, antibiotics, IV fluids, and was ultimately transferred to our institution for a high level of care, but not necessarily for transplant evaluation.
So I can just quickly share this CT, and Dr. Trapp, I know clearly this patient is very ill, and one kind of guiding question I have, I really just would love your thoughts on the data, is how can you tell if the liver is kind of the main driver of what's going on, or kind of a bystander to this process? What are your thoughts on that?
So these labs are horrible, right? And we can get really bogged down talking about each and every one of them, but I think that your question is a very good framing for trying to understand what's going on with this patient. So when you look at this CBC, right? The hemoglobin low, we see that in people who are bleeding, but you can also see it in people with a bone marrow process. A platelet count that is low. That's a classic finding for somebody with severe liver disease. But you will never see a platelet count of 5 because of cirrhosis or alcohol-associated hepatitis. You'll see a platelet count of 20, but you will not see a platelet count of 5. And when you see that, if you are attributing that to a liver disease process, you are doing so at the patient's risk. Okay. So there's an immediate red flag that something is happening. There are people with cirrhosis, alcohol-associated hepatitis that can drop their platelets to 5 because of things that are affecting them, like infections, right, or the medicines that you've been giving them. But that is a serious red flag. Then the other heme labs, as we're on this topic, a D-dimer 3500 means nothing. A haptoglobin less than 20 also means nothing. These things are just, you observe that with severe liver disease. Schistocytes should not be observed. Now, when you have a patient with an INR of 3.9 and platelet counts of 5, or let's say that the platelet count was slightly higher, a natural question to ask is this a patient in DIC? Or is this a patient who has a coagulopathy due to liver disease? And they share many of the same abnormal lab values. One of the differences being that factor 8 should be, at least at some point, should be low in people with DIC. And here we have a sky-high factor 8, which in many cases identifies that at least this person's coagulopathic process is in evolution, or that there's something that it's not, or that there's something that is in fact related to the liver. So there's a bit of a mixed picture. I'm super nervous about what's happening systemically to this patient, clued in by the platelet count of 5.
Yeah, absolutely. And it sounds like, at this point, the person has been transferred to University of Colorado, and it sounds like the hepatology team is kind of consulting at this point. What would you recommend as next steps here to kind of evaluate that question of, is the liver driving this, or a bystander?
Yeah, so the first thing that happens is exactly what's going on, where you do a broad evaluation. So you're looking to see if they have a stone and cholangitis. To some degree, that's been done with the ultrasound. You have blood cultures that have proven that they have an infection, and we're already starting to think about how this could be an extrahepatic process on that basis. And I'm not anchoring on it, but I'm certainly worried that a lot of this could be driven by this infection, and I'm trying to think about where that infection might be coming from. When I start to see this degree of coagulopathy and thrombocytopenia, I think about primary hematological processes that can affect the size of the liver and the spleen, lymphoma, leukemia, and I will be phoning a friend to see if we can do any additional studies on the blood. But at this time, I'm hoping that I'm covering the infection at the very least.
Mhm. Any other questions you want to ask?
Well, so I saw a question in the chat as about why wasn't there contrast. So yeah, I had the same question, and so this CT was done at the outside hospital before this patient was transferred in, and my guess is that there was no contrast because of the presumed AKI at the time. And I don't have any other further questions right now. But I guess for Dr. Tapper, so from a liver perspective, so in this case, HEP was consulted and provided recommendations. So I guess in this case, what would your recommendation be to the ICU team for what further workup should be done?
Yeah. So the day one's activities are to make sure that we're controlling the infection and ensuring that we are figuring out whatever triggers could be resulting in the very high lactate. So we're thinking about just optimal supportive care. Is this a person with occult hyperperfusion, or are they just severely thiamine deficient? Is there some other toxin with some mitochondrial stuff that needs to be identified and some kind of anti-toxicological intervention provided? That's one. Two, we're probably doing a proper hunt for infection with a contrast enhanced scan. I brought up cholangitis because this person is encephalopathic. They have severely abnormal liver numbers, and they have proven cholestasis. So it's just on a differential. I'm not sure that I would go straight to an MRI. But during this night, I want to know if there's a role for if there's any other places where source control for this infection ought to be pursued.
Exactly. And so that's pretty much the course that unfolded within the first 24 to 48 hours of presentation. I mean, this patient was treated by the MICU team. I don't have the exact sort of course up, but it was like broad infectious workup slash sort of management with fluids and antibiotics. And the key thing that I think I'm seeing in the chat, and like as you mentioned, Dr. Tapper, once the patient was sort of a little bit more stable, hepatology recommended an MRCP. So the third aliquot is basically the result of the MRCP. So the MRCP was with and without contrast, and it showed hepatomegaly with innumerable liver lesions. And we can actually pull up the MRCP as well. Bilateral enlarged kidneys with multiple masses, thickening and enlargement of the bilateral adrenal glands, and a modeled T2 hyperintense signal in the thoracic and lumbar spine.
And I can actually share this. So let me go ahead and share my screen. Oh. All right. So there you can see kind of the innumerable lesions here.
Yeah, and it's a huge liver. Man, oh man.
So maybe at this point, we can, we just love your thoughts overall, Dr. Tapper, but it might be helpful to just kind of talk about how you think about liver lesions in general, like how you think of a differential for that, and maybe how you would apply that to this patient here.
Yeah. So I just want to I think that when you hear a story about a 20-year-old man with 2 weeks of jaundice with known polysubstance abuse, it makes sense to assume that there's alcohol-associated hepatitis. And when you assume that that's happening, you definitely want to look for an infection while keeping an open mind about other possibilities. And so even for somebody who, because of the implicit bias that I have, informed by day-to-day clinical practice, like I would have anchored on that possibility, and I did so in the first 5 minutes of this discussion. The adequate care for that person would involve looking very broadly for sources of infection that would then cause you to reevaluate your initial differential diagnosis. And I would routinely look for an infection in the urine, the lungs, and the blood. Everybody would get a blood culture. And then Staph aureus is a super weird bug, and I would definitely be doing cross-sectional imaging in this case to rule out a stone or in my mind, the things I had seen along those lines were things like abscess, renal abscess, psoas abscess, and the like. And so once I get this information, now I'm challenged to try to go back and figure out what it could mean. And I know at this moment that the differential has widened far beyond anything that I would have ever expected, given the epidemiology of this particular presentation. So when somebody has innumerable liver lesions that are accompanied by liver lesions in other organs, you might find some imaging characteristics in that liver that would clue you in. But there's really nothing non-invasive that you would ever be able to do without tissue in this case. So whereas you are taught that liver cancer, primary liver cancer, hepatocellular carcinoma, can be diagnosed with imaging alone, it presupposes that the person has cirrhosis. In this case, we don't have that. And then all of the imaging characteristics are based on based on the multiphasic sort of contrast enhanced scan. But those rules don't apply when it's so widespread like this. So there is no way that I can reliably, non-invasively determine what's happening. And given that it's so widespread, understanding what the primary might be is unclear. I'm still super worried that this is a primary heme process. So it could be that the tissue I seek is like flow cytometry of the blood. But this is a person in whom I want the dust to settle as quickly as possible on the underlying septic process, where I know that at least the coagulation function stuff is stable or getting a little bit better. And then I will find the lesion that is most amenable to the least invasive path for a biopsy. So that's unfortunately, in terms of imaging for this, there's not much else. But if you want to talk about in general imaging, I could.
No, I think that's great. I mean, I think the reason I wanted to sort of present this case in the first place is because when we were being consulted, like the sort of the narrative, like at the institution at large, and sort of the narrative we got from the transferring hospital was that this was very much going to be either like a DILI or like a
Yeah,
drug-induced liver injury or an LCAP picture.
yeah,
And I think everyone was sort of anchoring on that. But the turning point was when my attending was the one who like came and saw the patient, and she was the first one to be like, I don't think this is a primary liver process, and we need to get really good cross-sectional imaging as like as the best next step and consult heme. Uh,
yeah.
and I think it was just like amazing to see how she was able to figure out that this was probably not a primary liver process, despite sort of all of the bells that were going off suggesting, like an ALCAP or DILI process.
Yeah. So, like the liver is often a bystander, and we spend a lot of time in clinic and on the wards trying to explain that. But the liver is scary, and so once you see something that's abnormal, people will often anchor on it. And so it is very there's like a hyperloop tunnel between hematology and hepatology. So like people, we're getting referrals and we're sending them referrals. It's very common to see a presentation by way of abnormal coagulation or blood indices go from one to the other because the processes present in similar ways. I mean, what's confusing here is that the story also included a standard setup for a very common presentation in our hospitals, which is alcohol-associated hepatitis. But once you start to see some of these things that don't sit too right, just the fact that you have jaundice doesn't mean that you have a primary liver process. You could have infiltrative liver diseases, but you can also have the cholestasis of sepsis, which happens in the ICU all of the time and can look just like this. And infection is extremely irritating to hepatocytes too. So you can always have, you're not necessarily going to have an AST of 600, but you can definitely have an irritated liver just from a broad systemic process like that. So it's very important to think about these extrahepatic processes, and obviously your attending was clued in and quite wise here. The one thing I want to bring up about drug-induced liver injury is I recently had a patient that showed me a condition called pilosis hepatis, wherein the drug-induced liver injury pattern uh, presents on imaging as multiple large masses within the liver, and then it resolves when you stop taking the herb or medication that you're doing. So the masses in the liver can still be part of the drug-induced liver injury complex, but it's the fact that it's all over the body that would have led me never to have mentioned that before. But still, there are still things in here that are that ring true for a primary liver process and DILI that you wouldn't be wrong to think about, but you would be wrong given the preponderance of evidence of things going on outside of the liver right now.
So like in that case where DILI causes these liver masses, what are those masses like made out of?
I don't know.
Yeah,
You biopsy them and it comes back very confusing. is not something that the average pathologist has looked at frequently. And so this is one of these things where I wish that there was a solid answer, but we can't without we can't do hepatectomy, and we certainly don't want to wait until autopsy to get all the tissue. And so we are left trying to sort this out together with the patterns that we've gleaned from the patients we've seen.
Yeah, and I see a question in the chat about whether or not the platelets respond to antibiotics, and just sort of looking at this patient's platelet trend, they kind of bounce between, in the 10s to the 50s, and it's kind of hard to interpret because I think he was getting daily, like daily transfusions of platelets and FFP and packed red cells as well. So for the final aliquot, it'll be the results of the pathology or the biopsy. So IR biopsied one of the masses in the left lobe of the liver, and it showed diffuse large B-cell lymphoma, which is the final diagnosis.
Yeah, so we can get your thoughts afterwards, but maybe maybe Dr. Tapp will just pass the mic to you first to just hear your overall reflections of this case. It was really kind of powerful to see how, when the time was right, you kind of had an inkling that this was perhaps the liver being a bystander, not the primary driver. So curious about your overall reflection of this case before we hear from Hirsch about kind of what he took away.
Yeah, so this is a rare presentation of a relatively rare condition, disguised as a common presentation of a common condition. And I wouldn't say that I routinely diagnose diffuse large B-cell lymphoma, but it happens it happens enough in clinical practice. And so I think every hepatologist has had one of their patients or has met a patient like this, and I imagine that your attending has experienced this in the past, and they were guided by that. But the key things here are like thinking about the stuff that's weird, right? That's outside of what you'd expect. And I would just say the stuff that I wouldn't expect for severe liver injury, the platelets of 5, which we've beaten to the ground, okay? A lactate of 17, the Warburg effect entered the chat, and I love that. Which is the preferential glycolytic pathway that cancer has. But a lactate of 17 you can definitely see in somebody who was starving and drinking. So it's not one. I never check ceruloplasmin, and I don't want to derail us. I don't want you checking ceruloplasmin.
No, please derail us. Tell us not.
What was that?
I was like, please derail us. Why should we not check that?
Oh, is that so point one is ceruloplasmin is made by the liver, and so if you check a ceruloplasmin and it's 82.7, then you know something very weird is happening to this person with liver injury. In fact, I have never seen a ceruloplasmin of 82.7. That's largely, I would have guessed 8.7 for this person. Now, one is Wilson disease is what you're hunting for with ceruloplasmin. The test characteristics of this test are horrible, right? So the positive predictive value of a low ceruloplasmin is 3%, okay? And maybe 8% if you go based on studies that are 30 years old. So that means that the vast majority, in fact, close to all people with a positive ceruloplasmin do not have Wilson disease. So realistically, the only way you're going to be able to diagnose Wilson disease in a patient like this is on explant or on biopsy. And the alk-phos to bilirubin ratio is often quoted based on a very old study from the UK, where what you see is a very low alk-phos to a high bilirubin. That's a so-called classic finding that you might find even on the transplant boards, but you'll never see it in the hospital because it just doesn't happen. It just doesn't happen that frequently. So there's a lot of classic things out there. If you did see a very low alk phos and a high bilirubin, you would think about someone who's hemolyzing, and they have liver disease if they have liver disease like this, and that would be classic for Wilson disease too. But you would not diagnose them based on the ceruloplasmin alone. You'd be doing a liver biopsy or transplanting them if you thought so, and then burning their liver for copper. So, anyways, when I saw that platelet count, I knew something was up. When I saw the ceruloplasmin, I'm not saying I'm like that was super odd, and then I knew I needed that CAT scan. So as soon as I got a proper scan, and there was a point like, oh, it wasn't done because of a creatinine. This guy is in the process of dying before your eyes, and so I this is someone who deserved a contrast enhanced scan. In this case, he got an MRI, and that's great. But if you did a CAT scan with contrast, I don't want you to feel guilty because there's no way to look inside the liver without contrast. And he needed that for a diagnosis. And not doing that contrast delayed his diagnosis substantially. And in this case, it may have been delayed by a day or two, but for him, that is substantially. So that's all I have to say about that.
Yeah.
Do you want to share your reflection?
Well, no, I totally agree with all of those pivot points. And I think when this patient was transferred to us, we were sort of most concerned about the lack of good cross-sectional imaging um, at that time. And yeah, and I think, a lot of times when we see patients with severe liver injury or severe like liver dysfunction and their labs are all wacky, like I think sort of the impulse is to kind of just be like, oh, the liver is causing all of that mess. But I think actually digging into the mess and seeing that, the magnitude of how low the platelets are and how abnormal the CBC is actually points away from the liver being the driver, is like one of the key takeaways for me here. Like I hope to become a hepatologist one day, and I feel like learning to differentiate between when the liver is driving versus just a bystander is something I'm really trying to figure out. I just want to round out the patient's hospital course as well, while we're here. So he has lymphomatous infiltration from DLBCL of multiple organs. And then his course was ultimately complicated by renal failure, the MRSA, the bacteremia that we mentioned, and we were never able to find a source. He also had candida arthritis of his knee and profound coagulopathy. Ultimately, after 1 month of being at our hospital, he suffered an ST elevation, or he suffered an LAD infarct, presumably in the setting of this profound coagulopathy, was deemed not a safe candidate for PCI, and had cardiogenic/obstructive shock from tamponade, and ultimately passed. So I'm not sure if earlier diagnosis would have really helped change the course here, but I kind of do wish we would have intervened sooner or figured it out sooner. Yeah, thank you so much, Dr. Tapper, for this wonderful discussion. Anything else, May?
Yeah, no, I think I just want to thank both of you for presenting. I think I think when you present cases like this, I think it's a way to honor the patient's journey, and I think we all learn something from this. So thank you for taking the time to put all this together. And Dr. Tapper, it was really amazing to see you kind of appropriately so focus on base rate, like what is most common and generally kind of young folks, but then at the appropriate time pivot when the data wasn't adding up. So that was really inspiring to see you do that. And thank you for your outstanding teaching. Just wanted to see if you wanted to take this time to highlight any one or two teaching points you wanted people to take away with. If not, we will end the session, but I'll pass the mic to you in case you wanted to share anything else.
Yeah, this is super sad to hear of his outcome, and I'm not sure there's anything that could have been done differently. Like his labs on presentation spoke to a severity of illness that was probably challenging to ever overcome, and that the care that he received was was without question that gave him the best shot. And it's so sad to have an experience like this with a patient passing so young. but he definitely taught me something, and and it clearly taught you something. And so I'm grateful to be a part of this discussion.
Well, thank you so much. Anything else you wanted to share?
No, I just I think about this case probably every week. Yeah.
Well, thank you, Dr. Tapper, for making this session happen and for your outstanding teaching. Thank you for presenting this case and for allowing us to learn from his journey. And thank you all for tuning in. It was really good to see you all. And we'll end the session there. All right.
All right. Thanks,
Take care, everyone.
Okay. Thanks for having me.
Bye.
Yeah, of course.